Hello everybody, welcome to the Moral Healthcare YouTube channel. If you're here for the first time, welcome. If you're coming back, thank you. Today I'm going to talk about how to create change in America using a Healthcare in America commission, and I'm going to be talking about how I would see that being structured. Those of you who have seen some of my other videos know that I'm a big fan of Jonah Berger's The Catalyst book, as well as lots of other cognitive psychology techniques. But I think something that Professor Berger hits on that's very critical is this quote: catalyzing change isn't just about making people more comfortable with new things, it's also about helping them let go of the old ones. And the old ones includes many of the ideas that have been propagated by conservative outlets and media and writers for decades now. And if you've seen some of my other videos, I go on more about that there, but I won't do that so much today because I want to talk about how to create change. So one of the problems with changing people's minds on universal health care is, as a concept, it's a boulder. In The Catalyst, he talks about changing people's minds on things that are pebbles, like changing your shampoo, or things that are boulders, like this. Big things, changing a political party, changing someone's mind about universal health care. These things are boulders. And just like if you're trying to move a pebble off your driveway, a little hose will do it. But if you have a boulder, you might need a fire hose or many men or something to move a boulder. So changing someone's minds on something that most people have pretty strong opinions about, like healthcare, is a big deal. You can change people's minds individually, and ideally that would be the way to do it, to have conversations with people and use the techniques of cognitive psychology to interact with them, have an exchange of ideas, have them actively think, and so on. But it's just not practical to do that to a population, right? If we want to have political change, we don't have to move everybody. We don't have to change everybody's opinions. But on the football field of ideas, we at least need to get the people between the 40-yard lines and maybe even between the 30-yard lines to at least look favorably on the idea of universal health care. So you can't just do that one-on-one canvassing door to door. We have to have some mechanism of changing more people's minds on a larger scale. And just to put the idea of making commercials out of your head, I mean, we as progressives have been making the argument for single-payer, Medicare for all, other forms of universal health care for decades now. And it's become quite clear that just telling people what the right thing to do is doesn't work. A whole variety of reasons covered in another lecture, but just telling people what to do will not change their minds. Telling them why they're wrong in particular doesn't change anybody's minds. So we need to figure out some way to have concentrated efforts, that's that fire hose, on smaller groups and with expert technique. So how do we do that? We need to saturate small areas to begin with. And while we're doing this, while we're trying to saturate the areas with ideas and change people's minds, we have to learn what works. Because right now we don't have a whole lot of ideas about what works. There are some tested phrases and framing and messaging, to be sure, but there's not a big concerted effort that I'm aware of, and if you're aware of one, send it to me, on how to figure out what works and what does change people's minds on universal health care. We have some ideas, but we haven't done anything in a systematic way to test it and see if we change people's minds, and if we change people's minds, do we change them for more than a few days? Is it something that lasts weeks, months, permanent? How do we change people's minds? How do we change people's minds enough that they support the idea of universal health care? So we have to learn what works, and then we have to duplicate it. And we have to move it around the country and move it around to various congressional districts and so on and so forth. And then, once we have a messaging system and a way of communicating and a way of framing things that changes people's minds, then we can start worrying about saturating media with some of the concepts. Because again, it's something that if you haven't seeded the ground, if in cognitive psychology terms, there's no availability and recency of the ideas that we're talking about. Oh, universal health care, that would benefit me, that would benefit my neighbors, etc., etc. If we don't have those kind of ideas in people's minds, saturating the media isn't going to change anything. For the counterexample, because the right wing has been so successful for so many decades, when you think of healthcare in Canada, if you're an average person, not an advocate, if you're an average person, what comes to mind? Waiting times, right? Delays of care, denials of care. I know that's not true. Don't send me any messages about that. But the right wing has been so successful in planting those messages that that's what comes to mind. And we have to figure out a way to do better and to change people's minds and to make the things that we think about when we think universal health care, we need to make those the things that are immediately available in somebody's minds when they think of universal health care. So, off we go. I am a big fan of Senator Estes Kefauver and the Kefauver Committee. I will tell you how old I am because I know about the Kefauver Committee because it came up in Mad magazine when I was a kid in the 1960s. And the Kefauver Committee was the committee that made people aware of organized crime in America. Before the Kefauver Committee, most people had not heard of the mafia. Most people had not really paid any attention to organized crime, did not perceive it as a real problem. But Senator Kefauver knew it was a problem, and he introduced a resolution that would create a committee to investigate organized crime's role in interstate commerce. And this is from Wikipedia, by the way. Feel free to look it up at yourself. I was reminded of it at the Mob Museum a few years ago because they had a display about it. Anyway, the important points are that they had committee hearings, and they had the hearings in 14 cities. They heard testimony from over 600 witnesses. Many of the witnesses were high-profile crime bosses. I won't read all this to you, but they had big names testifying. They named names. A lot of politicians who were either brought before the committee or were named by other witnesses in the committee, had their careers destroyed. But to me, here's the important thing. The committee's hearings, which were televised live, just as many Americans were first buying television, made Kefauver nationally famous and introduced many Americans to the concept of a criminal organization known as the Mafia for the first time. I have noticed that President Biden, right now, after the passage of the American Recovery Act, is going around the country, and he's bypassing the major media because of the power of local news. We can talk about that later, but I think it applies here too. Trying to get a platform on MSNBC so the same people who are in the choir can listen to you will not do it. We need to figure out a way to get more penetration and to get more attention paid. It can't be just a blurb, right? It has to be something sustained and something meaningful, and I'll get to that in a minute. They got huge public audiences. They got huge television ratings. It says an estimated 30 million people tuned in to watch the live proceedings in 1951. And at the time, 72% of the population were familiar with the committee's work. A friend of mine said, you don't propose to make this a criminal proceeding against the medical industrial complex, and no, that's not what I'm proposing. Here's what I'm proposing. Just like with the organized crime analogy, there are things that are important to point out to people. The detrimental effects on society of the current healthcare system. And again, if you're watching this, I expect you know all this, but I'm going to run through it real quick anyway. There are real detrimental effects to society of the U.S. healthcare system as it is. Endless suffering. And I'd like to quote Uwe Reinhardt that America is capable of unfathomed generosity and unfathomable cruelty at the same time. So there's a lot of suffering in America because of lack of access to health care and waste. This is, if you're listening to this, you know what I'm talking about. Lost wages and profits due to illness and near illness and so on. Financial toxicity, the statistic I like is that at 2 years, almost half of patients who are diagnosed with cancer have burned through their life savings. Talk about the profiteers, and this would be analogous to, I guess, the organized crime. It's not crime per se, but it's profiteering. And there is an incalculable inefficiency that we never talk about, and we pretend that business is infallible, and so inefficiency, heaven forfend, but you know, the bureaucratic nightmare of the current healthcare system, the wasteful spending, and another thing I've come to, a term I've come to love is bullshit jobs. Bullshit jobs are jobs that, if they disappeared, would at worst have a neutral effect on society, and at best would improve society. And if you go through the medical industrial complex, say no more. You would need to construct panels just like they did in the Kefauver Committee, and you'd have to figure out how to do that, and you'd have to put some preliminary panels together, and then you'd have to see what works. But what I would see is panels of citizens who are victims, providers who are victims, I'll leave that alone, former industry insiders to delineate the predatory practices. I often like to cite Elizabeth Rosenthal's An American Sickness, which sort of lays out in great detail the rogues gallery of malefactors in nice, organized fashion. So I highly recommend you look at that, but I'm going to go through it real quick here. And then I think we need something that I call DeFrightening. And I think we need to have people telling stories of healthcare in other countries from the OECD, and we need to have enough of those stories told about the benefits of a universal healthcare system, and there are a lot. The benefits of the universal healthcare system, so that those things become recent and available in people's minds. When the subject of universal healthcare comes up, they don't immediately think delayed care, denied care, loss of freedom. They think of rapid care, excellent care, no financial toxicity, etc., etc. All the things that you already know, but you get the idea. But I think the DeFrightening is important because, again, for a lot of cognitive psychology reasons, not only do you have to convince them that your new thing is good, you have to convince them to want to let go of the old thing. And we all know the massive flaws in the old thing, but people who are not exposed to the healthcare system on a routine basis are not generally. So unless you've had an illness or had a family member with a serious illness, you don't really know the deficiency of the system. And if you're lucky enough to be employed with a job that provides health care insurance and you're not really using it other than for the occasional primary care visit, you think everything's hunky-dory until you get sick. Again, I know you know this stuff, but I'm just reiterating it. I have a point here about asking. I view these two groups as the start of asking, not telling. In the Catalyst book, he talks a lot about not telling people what to think, but asking. And citizens and providers that can tell stories is a way of asking. It's a way of eliciting stories and eliciting experiences that aren't telling people what to think, but they're elucidating the problems with the system so that people who, again, haven't run into the system don't know about. So I think it's very important to have groups like that that can, one, create empathy, but two, tell stories that people don't know about. Just like people didn't know about the mafia, people don't know the horrors of the healthcare system that we see on a routine basis. So in An American Sickness, she has these chapters here. about the various segments of the medical industrial complex that are causing the problems and creating the high costs and creating the inefficiencies, et cetera, et cetera. As you can see, insurance is first chapter, naturally, but hospitals, physicians, and physicians' roles in all this is diverse. Pharmaceutical companies, medical device manufacturers, testing and ancillary services, contractors, builders, coders, collections, other new medical businesses, the people who do research and good works for profit. And she spends time talking about non-for-profits that have been corrupted or been used for financial gain and profiteering. Again, there's going to be some good stories there too. The problems with conglomerates, and when I used to teach health policy, we talked about integrated delivery systems as being a potential cure for a lot of what's wrong in the American healthcare system. And here, almost 10 years on, we see that that's not worked out. She talks a lot about healthcare becoming a pure business, and again, these are things that we would explore. So just deconstructing these a little bit and trying to figure out how we would do this. And what I would think would be citizens and providers would be the way to start the conversation, to have testimony and interactive testimony and questions and answers, patient family narratives, conversing and explaining their experiences with the healthcare system, how they have lost agency in decision making, how they've lost freedom, healthcare freedom, economic freedom, paradox of choice, etc. We need to talk about endowment. People who have health insurance like their health insurance, especially if they haven't used it. We need to punch holes in the myth of employer-based insurance. We need to talk about the cost of inaction. If you are satisfied with your health insurance, or you don't have health insurance and you're satisfied with that, there is a cost to not changing things. If you get sick and you are one of those people who has cancer and in 2 years you've burned through your life savings, that is a big deal. That's a lot of instability. That's a lot of uncertainty. Same with the next bullet. What happens if you or your family get sick? We have to punch holes in the love affair that people have with their theoretical health insurance. Most people, after they've used their health insurance and had a serious illness, aren't so in love with it anymore. So we have to make that clear. And the sunk cost fallacy, the idea that, well, it's been this way for 50 years, we're not going to throw all that out. It's another cognitive psychology issue, but we can show that it doesn't have to be this way. We have to unmoor the anchors. The anchors are the things that are keeping people into their old systems, that make them not want to move. We have to give them new anchors. We have to show them the patient experience in the OECD. The one that I always like to talk about is just something as basic as choosing a health plan. I don't want to choose a health plan. I want a health plan that covers everything with minimal co-pays and minimal deductibles and minimal hassle. I don't want to sort through 10 different plans and figure out which one has my network and providers and on and on. That's an experience we have in the U.S. that pretty much nobody else does. Even in Germany, where there are sickness funds and you have to choose between the sickness funds, Germany mandates what's in the plan, the minimum that's in the plan. So everybody basically has the same plan. There are, wrinkles here and there, but, we just accept that stuff as a routine, and it's nonsense. Anyway, we have to show them that there are better choices out there, because clearly there are. Right now we don't have them. We have a lot of bad choices is what we have. So I think we also have to really unmask the cruelty of the system. I mean, the system is a time suck. It's a money suck. It leads to worsening illness for delayed care. It causes endless suffering and stress. Imagine being uninsured and the stress of getting sick and not knowing how you're going to deal with it, or a child in particular getting sick and how are you going to pay for it, and the complexity of the system, which I just alluded to. Same quote as before, we really have to help people let go of the old ideas, because they're not very good ideas. And if you're in the healthcare system, you know they're not good ideas because you see it every day. And the cruelty of the old system, the current system, needs to be a new reference point. We need that recent and available in people's minds so that when they think of the current healthcare system, they don't think, and a few still do, of the best healthcare system in the world. They think, what a cluster this is, then why are we still doing it this way? So that's going to take a lot of work. There's a concept called, technique, I guess I should say, called deep canvassing. And what deep canvassing is, as opposed to going door-to-door canvassing in a political campaign like we used to do and hand out pamphlets and tell people who to vote for and stuff like that. Deep canvassing is a technique whereby you have a conversation with the person at the door. The things that have been studied and as examples are changing people's minds on either immigration policy or policy towards LGBTQ people. And the way they do this with deep canvassing is they go and have a conversation at the doorstep. And they tell their own story. If they have a friend who's LGBTQ, or they are, or an immigrant, whatever. But the idea is that you create empathy, you have a conversation with the person. And as I said, I don't think we can do that in a one-on-one manner and have any meaningful hope of change. But if we do it in a forum like this, I think we can. I think we can talk to audience members who are not predisposed to universal healthcare and have conversations in an audience that might move more people. Is this going to happen? I don't know, but I think it's really worth a shot. We know the stories that will do this. I covered a lot of that, but there's a lot more that needs to be worked out, obviously. And there's my favorite quote again. One of the things we have to do is change the frame from market norms to social norms. Dan Ariely, in his book Predictably Irrational, talks about this, and the example he gives is that if you were to ask a law firm to do some work for your nonprofit corporation, and in one instance you ask them, well, would you do this work for just $25 an hour for us? Versus, would you do this work pro bono for us? The answer is they will not do the work for $25 an hour, because what you've done is you've made that a market transaction, right? You've made it a market transaction with a steep discount for their work. Whereas if you ask them to do it pro bono, that's a social transaction, that's a social norm. You're doing something good for the community by helping out a nonprofit. They'll almost always do it for the social reason. They won't do it for the market reason. And this is what we see in healthcare. I don't know what the numbers are, but a good chunk of Americans think of healthcare as a commodity, a market good, and the rest of us think of it as a social good. And we have to do some work to change people's minds and convince them that it is a social good. It's a big deal. In one of my other videos, I talk about the 2012 GOP primary, where they ask about Ron Paul, about a hypothetical person who chose not to buy health insurance, and he gets injured or gets a serious illness. And Wolf Blitzer asks, what do you do with that guy? You just leave him there, or do you take care of him? What do you do? And a bunch of people in the crowd started chanting, let him die. And that's a market decision, right? As an individual person, if you saw somebody on the street and they were injured, you wouldn't take a market perspective, right? You'd have a social norms perspective, and you'd try to help that person. You'd try to get them to the hospital, etc. And we really need this from providers. This is medical professionalism, nursing professionalism, really, all healthcare professions, professionalism. We can't accept that this is just a market transaction. It is not. And we have to be forceful about that. We have to make that point over and over and over again. That, yeah, you might want to consider this a market transaction. And yes, there's going to be some money changing hands for the services. But this is a societal problem. And our professional duty is to take care of patients. whether that patient is in front of us or is a theoretical patient that we're advocating for, that's part of the profession. We have to do that. Another concept that Berger talks about is finding the zones of acceptance. There are ideas along the political spectrum that people who are on the opposite 20-yard line, say, of your political ideology, will never accept. Universal health care probably being one of them, but there's other ones. But in the middle, between the 30s, maybe even between the 20s, there are zones of acceptance, and there are ideas that are not immediately dismissed out of hand. I mean, you've seen the polling. Single payer, Medicare for all are highly popular on a just ask that question basis. But as soon as you start adding other things to it, well, it will change your private health insurance, it'll change this X, Y, Z. The numbers drop and drop and drop. The idea of universal health care, however, the fairness idea, is very popular and has high support, 65, 70%, something like that. So it's a highly popular idea. It's when industry and conservatives start the campaign of, as Wendell Potter calls it, fear, uncertainty, and doubt. When they start that campaign, that popular universal health care drops down very quickly. So the initial idea is very popular, and that's a way in, right? It's a way to get people to at least accept that idea of fairness. So it's very popular. Administrative simplification is very popular. The wasteful for-profit middlemen can be pointed out. The premiums, the prior authorizations, denials, appeals, grievances, the explanation of benefits forms, choosing health plans like I talked about before. Those are things that people hate, right? If they've ever dealt with the system, they hate those things. So the idea of getting rid of them is quite popular. But again, we need strategy. Putting in place price controls, very popular, right? You ask people about Medicare, CMS, negotiating drug prices, very popular. People know the prices are too high. They also know that the industry is profiteering. Just like the rest of us, it's very difficult to tell exactly who's profiteering how much and what to do about it. But the idea, the price control idea, is popular. And then we have to do more research to figure out what the better targets are. There's a lot of them. There's a lot. What's the joke? It's a target-rich environment, but we have to do some messaging and testing and framing to see what works best. And if we do commissions like this, if we do hearings like this, we'll eventually figure that out. We might figure it out pretty quickly with what works, what changes people's minds, what's popular, and so on. We also need to do a little more research on asking for less. One of the things, several of the things we're dealing with right now are the ideas of buying into Medicare at a younger age, expanding Medicaid to people that normally wouldn't qualify for it, immediately providing insurance to people who lose their jobs, either through COBRA or something else. Those are things that can work. They're not Medicare for all. They're not single payer straight out the gate. But if they get people in, and they get people with a little bit of ownership, you get some endowment effect, right? So if you get somebody that loses their job and gets goes on a public option, for example, or goes on straight Medicare, after they've had it for 6 months or a year, it becomes theirs. And then trying to take that away is a big deal, right? Get your government hands off my Medicare, same ideal. You become very possessive of this thing because you endow it with a lot of positive traits and it's working for you and you don't want to let it go. So asking for less to get those little things can lead to the bigger thing, right? Because you get acceptance of what you're advocating for. So more about finding these zones of acceptance. How do we do that? Generate active processing. One of the things Berger talks about is in those conversations about with deep canvassing or other conversations when you're trying to change somebody's mind, what you really want is them to think. One of the biggest barriers to change is that people go into reactance mode, and if you start talking about universal health care, They just silently shoot down every idea, everything you proffer forth, they're going to shoot down. They're not actively processing. They're in defensive mode, and they're going to shoot down everything you say. What you want is to have a conversation, and you want to generate active processing. And you want to ask them about, well, how's your health insurance work for you? You know anybody that it hasn't worked for? What happens if you get cancer and can't work after 6 months? What happens to your insurance? Have you ever thought about that? That kind of thing. I think these commissions could do that. I think they can generate those conversations. And even though they would be on a small scale in a room, that stuff can not only be replicated, it can be recorded, and it can go viral, and it can go to local news media outlets, especially if you do sessions in places where you can get news coverage. I would add another idea from Ann Applebaum. She was talking about Trump voters, but I think the things all apply in healthcare too. Appeal to patriotism. Daniel Allen and Edwin Chemerinsky and others talk about expanding rights and equality of opportunity and promoting the general welfare are popular, and they're patriotic, and we don't claim them often enough, and we have to do better with that. We have to use the disaffected. In her case, she was talking about voters, Republican voters against Trump, as being reliable witnesses to why they changed their minds. People like Wendell Potter can serve that purpose, and there's tons of people with stories who may have been staunch conservatives and had a run-in with the healthcare system and now want universal healthcare. She also mentions that humor melts fear. We'll have to work on that. I don't know a lot of good universal healthcare jokes, but you know, you have someone maybe like Al Franken running a session or two, might work out. And for me, I like to talk about Matthew 25 because I was raised Catholic, but you know, the golden rule, every religion claims to have the values of the golden rule. Every religion claims to have compassion as its highest virtue. And I get that from Karen Armstrong, who wrote a lot of books about the Bible and other religions in the Middle East. But depending on the audience, those should be helpful too. Some other ideas from Berger's book to keep in mind. These will come later in the process, after we have a few commissions and sessions, and after we figure out what might make best messaging. But a couple of things he talks about are making things painless, like automatic Medicare and Medicaid enrollment for the unemployed, drive discovery. That means show people what it's like. If you enroll somebody in Medicare or Medicaid when they lose their job or a public option, and they test drive it, was a good way of putting it, they test drive it for 6 months, they may discover something that they like, or that at least is not as horrible as they thought. And also make things reversible. So if somebody says, well, okay, I'll try Medicare for a year, but I can go back, right? Yes, right, you can go back. Take advantage of inertia, because once they get in and they're happy with their Medicare or public option or whatever it is, they won't really want to leave it, right? Inertia, endowment, whatever effect you want, but yeah, they're probably not going to want to leave if everything's working for them. And I think we need to use uncertainty, as I talked about before, to show people how certain healthcare is in the rest of the OECD and how uncertain and tenuous it is here. He talks about this as getting people to unpause, meaning they're stuck in their position and aren't going to change, and he wants to unpause them and make them think and move forward. He talks a lot about corroborating evidence, and corroborating evidence is stories, like we've been talking about all along here. But I think on top of stories from regular citizens and other people who've been disillusioned, I think doctors and nurses are the mother lode of corroborating evidence. We all have 5 or 10 stories in our hip pocket that we can drop any time, right, about the inefficiencies and the cruelty of the system. I think the commission starts with those stories, the citizen stories, the doctors and nurses stories, and then this grows as the show travels and as we pick up experience and see what works and accumulate stories and create YouTube channels full of stories and so on. The commission idea also benefits from an all-at-once intervention. It's like an intervention on a family member where you bring everybody together all at once. This kind of commission event, hearing, brings that all-in-one immediacy to the session, right? Because you're hearing from all corners. You're hearing from patients and relatives and disaffected doctors or people who work with pharmaceutical companies, and then doctors and nurses telling stories, and on and on and on. It becomes a really intense experience of hearing what's wrong with the system and how we can do better. And as we do this, then we can think about dropping some truth bombs with media campaigns around the event. So if we get good sound clips, video clips from the events, those can become commercials, because then those commercials will hopefully get people to watch the whole thing or parts of the whole thing or learn about it, etc. That'll at least get the ball rolling. Berger talks about impactful sources. What are the impactful sources that of corroborating evidence that change people's minds? Well, there's a bunch of categories, but people like you, people like me, are influential on us. But you don't want 30 people like you, right? You've heard a few people like you, that's corroborating enough. But you also want people who aren't like you. And you also want people who are respected in the community, and that's, of course, why doctors and nurses are good sources for that. People you know, people you don't know, especially people you know well, or with whom you have multiple connections. People from diverse areas improve corroboration. The more independent sources, the better. People who don't have a vested interest in you or frankly, or what they're selling, right? Or unselling, I guess, in this case. This also goes for organizations. So if you're going to get someone like Doctors for America or the American Medical Association or what have you, you have to have variety, and you have to have the respect of the community and so on. So I think we have all that. That's the check, and check. We have these sources, and we can pull them together, and I think we can put on an impressive program. So with all this, we need to establish a new reference point. The current reference point is the status quo. And Uwe Reinhardt used to say that everybody's second choice after their choice is the status quo. So we always end up with the status quo because that's the reference point. That's where the inertia takes us. That's where the endowment takes us, on and on and on. So we need a new reference point. And we need a new American system. We need a plan for a new American system that becomes a new reference point. And is that going to be Medicare for all, or some other version of single payer, or some other version of universal health care, what have you? I don't really care. I want a system that's fair and universal, simple, affordable. But that has to be our new reference point, right? We can't let the reference point be the system we have now. We need a new reference point. And we need to try to get people to focus on that new reference point. Let go of the old thing, convince them of the new thing. That's it. I hope you'll comment or email me or let me know what you're thinking about all of this. I'd like this to be a collaboration. So let me know what you think. Thanks for getting this far. Bye-bye.